At previous hearings, we've heard numerous stories and data points that all said the same thing. Medicare and patients are paying more for certain services in hospital outpatient department than they pay at the doctor's office. We heard from cancer patients who are fed up with seeing the cost of their chemo increase when a hospital purchases their infusion center. We heard about a senior citizen whose cost for an annual shot went from $30 to $1,400 just because her outpatient clinic reclassified itself as an entity of the local hospital. And we've heard strong support for ending this payment disparity from experts and advocacy groups across the ideological spectrum, from the Progressive Policy Institute to Americans for Tax Reform. This amendment follows the nonpartisan Medicare Payment Advisory Commission's proposal to ensure that Medicare and seniors pay the same amount for certain services, regardless of where they are performed. First and foremost, this proposal would directly save patients billions of dollars in healthcare costs. It would strengthen the healthcare system more broadly by ending one of the major driving forces of healthcare provider consolidation, which has resulted in less competition and access to quality healthcare options around the country. It is not a secret that hospitals have concerns with these proposals. As I said in our last hearing on the topic, hospitals are integral. They're integral parts of our communities, and we recognize the effects of high labor costs, inflation, and ever-increasing government regulation. We know that hospitals and the services that they provide often lose money. We rely on emergency departments that are open 24 hours a day, 7 days a week, for example. But I reject the premise that the only way to make hospital financials work is to cross-subsidize lost leaders by making patients and Medicare overpay on certain services, especially when we know that these policies come with unintended consequences of consolidation and less competition. Figuring out how to more directly and accountably subsidize hospital services without unintended consequences is difficult, and we have more work to do on these proposals to ensure access to care is preserved. So I will withdraw this amendment, but I remain committed to advancing these policies on behalf of patients, and I implore the hospital community to work with us on broader reimbursement changes that preserve access to care while making these key changes to help patients and strengthen the healthcare system. Lowering healthcare costs is a top priority of mine, and I'm committed to additional work on these policies with the ranking member, Pallone, and members of this committee to follow up on these important steps we're taking today. Mr. Chairman, I yield back.
The gentlelady yields back. The amendment is, the gentleman from New Jersey is recognized for 5 minutes to speak on the amendment.
Thank you, Mr. Chairman. I want to thank Chair Rodgers for her comments, and if I could just develop a little on my opinion. As I mentioned in my opening statement, I am concerned that Medicare currently pays substantially more, sometimes more than 2 or 3 times, for low-complexity services delivered in hospital outpatient departments compared to a physician's office. This difference in payment for the same service provided at different sites of care increases the cost to the Medicare program and, more importantly, increases the out-of-pocket costs of beneficiaries. I believe that drug administration is a clear-cut example of a low-complexity service that can be performed safely in a physician's office. So I want to thank the Chair for the bipartisan work on this policy and the important investments that we can make in the DISH program with the associated savings from this policy. And I welcome continued discussions on policies that can lower costs for consumers and reinvest in our healthcare system. But of course, we have to closely examine any additional site-neutral policies to ensure that they do not jeopardize patients' access to care. And I look forward to working with you, Chair Rodgers, in a bipartisan manner as we consider any of the policies moving forward. And thank you again. Thank you, Mr. Chairman.